So move on to the diagnosis and treatment planning in completely edentulous patients. The successful complete denture therapy begins with a thorough assessment of patient's physical and psychological condition and determining a treatment that will deliver a functional complete denture that will satisfy the expectations of a patient. According to GPT-9, diagnosis is defined as the determination of the nature of the disease. And treatment plan is the sequence of procedures planned for the treatment of a patient after diagnosis. So what is the importance of first visit? Divan stated, meet the mind of the patient before meeting the mouth of the patient. So the first visit is most important time the dentist will spend with a complete denture patient. It is used to develop mutual understanding and trust. And treatment plan should be based on realism rather than hope, otherwise it may result in disappointment and frustration. Much information can be gained by the dentist before he ever looks into the patient's mouth. And the time spent during the first appointment can lay the groundwork of cooperation so necessary for a successful result. Move on to the principles of perception. The primary mode of data gathering in the examination is the visual perception. Simplest of it is seeing with eyes and interpreting with the brain. And the various tasks identified in this process are detection, discrimination, recognition, identification, and judgment. What is detection? If noticing something is the detection. What is discrimination? It requires distinguishing that which has been noticed for something else. What is recognition? Deciding whether this or at least something similar has been perceived on some previous occasion. What is identification? Moves process into specificity, which has been observed and can now be communicated. What is judgment? It allows something that has been observed to be placed within a spectrum of knowledge. So in diagnosis, there is a professional responsibility to omit nothing of consequence. A consistent methodical approach to examining patients is required. So these are the importance of patient education, that is an initial and continuing activity integral to and supportive of a treatment plan. The purposes are it informs the patient of their dental health and its significance. It gives the patient understanding of significance of edentulism, match the patient's expectation with reality of treatment potential, explain nature, use and shortcomings of the processes, identify alternative treatments and their consequences. Will help patient understand diagnostic procedures, diagnostic results, treatment plan, treatment to be provided, use of processes, continuing care and fees. It should facilitate the acceptance of treatment, acceptance of fees, continuing care. Coming to gait of the patient. The observations regarding the patient's walk, steadiness and the level of coordination can help in gaining an insight into the patient's motor skills and any systemic disease. So stamping gait or slapping gait, it is observed in sensory ataxia patients. Then hypokinetic gait in Parkinson's disease and foot drop. They have high stepping gait. And next one is the cosmetic index. At class 1, it is high cosmetic index. Class 2, it is moderate. And class 3, it is low. In high cosmetic index, it is usually appreciative and cooperative. In moderate cosmetic index, patient with nominal expectations. And in low cosmetic index, they are indifferent, uncooperative and place little value on the effort of prosthodontist. And coming to the mental attitude. Successfully wearing a complete denture is a learned skill for most patients and especially for new denture patients. Therefore, the mental attitude of the patient may play a very important role in the edentulous patient's ability to adapt and can be very valuable information for a dentist to help evaluate the ultimate prognosis of denture patients. Dr. House has classified complete denture patients into four mental attitude categories. They are philosophical, exacting, indifferent, and hysterical. So first coming to House classification. In 1950, Dr. M.M. House classified patients as philosophical, exacting, indifferent, and hysterical. This is the most widely used classification. What is philosophical patient? The philosophical type is the best mental attitude for denture acceptance. And these patients are rational, sensible, calm, and composed in difficult situations. They overcome various conflicts and organizes his time and habits in an orderly manner and eliminates frustrations and learns to adjust rapidly. Coming to exacting patient. It may have all of the good attributes of this philosophical patient. However, he may require extreme care, effort, and patience on prosthodontist's part. Patient is very methodical, precise, and accurate and makes several demands. Patient is comfortable when each procedure is explained and discussed with them in detail. Coming to the indifferent patient. They present a questionable or unfavorable prognosis. These patients are identified by their lack of concern and motivation and apathetic attitudes. Pays no attention to instructions, will not cooperate, and is prone to blame the dentist for poor dental health. An educational program in dental conditions and dental treatment is the recommended treatment plan before denture construction. And moving on to the last group, they are hysterical patients. They are emotionally unstable, excitable, and excessively apprehensive and hypertensive. And the prognosis is often unfavorable, and additional professional help is required prior to and during the treatment. And the patient must be made aware that his or her problem is primarily systemic and that many of his symptoms are not result of dentures. So that's all about the House classification of mental attitude, and there are various other classifications for the mental attitude of the patients. They are listed here. So by Alan Mack, he classified the patients into endomorph, ectomorph, and mesomorph. By Winkler, into hardy elderly, senile aged, satisfied old denture wearers, and geriatric patients who do not want dentures. According to IPWCDO, there are two classifications, maladaptive response and adaptive response. Gammer et al. It is a modified House classification into 5. They are ideal, submitter, reluctant, indifferent, and resistant. And the Ettinger and Beck's frail elderly, functionally dependent elderly, and functionally independent elderly. And Blum, reasonable and unreasonable. Then the classification 2 is cooperative, apprehensive, and uncooperative. That is, the apprehensive is also classified into self-conscious, anxious, chronic complainers, frightened, and obsessive or exciting. And finally, Frankel into 4. They are definitely positive, positive, negative, and definitely negative behavior. Moving on to the facial expression. This provides the information about the mental attitude and the presence of any disorders. And absence of any expression indicates loss of muscle tone, trigeminal neuralgia, plastic surgery, or disorders of central nervous system. Coming to the complexion, it is used to select the color of the teeth. It may also be indicative of the following conditions. If it's pale, then anemia or lack of nourishment, then ruddy, then polycythemia or chronic alcoholic. If it's bronze, then radiation therapy or Addison's disease, and bluish purple, it may be vitamin deficiency or cyanosis, and lemon yellow, it may be jaundice. Coming to the speech of the patient. The fluency and quality of the speech should be noted as it will help in arranging artificial teeth. If speech is altered due to poor denture construction, it should be rectified. And speech can also be altered due to the following pathologies. Hypernasality is a paralysis of palatal musculature, then hypernasality occurs. Then hoarseness of the voice, if paralysis of both vocal cords, excessive smoking. And finally, the breathing pattern. Abnormal breathing patterns may indicate the following. Heavy sighing if it's emotionally disturbed. Wheezing, asthma. Shortness of breath, lung disease or heart failure. Shallow breathing at rapid rate, pulmonary fibrosis. Erratic breathing, continuous hypoventilation. So coming to clinical history taking, it is a systematic procedure for collecting the details of the patient to do a proper treatment planning. Personal and medical particulars are gathered to rule out general diseases and to determine the best form of treatment for that patient. So first one is personal data. In this, the first one is name. It should be asked to enter it in the record for documentation. When the patient is addressed by his or her name, it brings confidence and psychological security, and it makes more comfortable for the patient, and it also gives idea about the patient's family and community. So next one is age. It's an indicator of the patient's ability to wear and to use dentures, and it is important to predict the outcome of the treatment, and this refers to the physiologic age, and it provides information about patient's expectations and care for the dentures, used to rule out certain systemic conditions apart from determining the prognosis, and good healing abilities shown by 4 decades of life patients and greater than 6 decades showing compromised healing. So next one is gender. Generally, appearance is a higher priority for women than for men. Though younger men often are concerned with aesthetics, males often grow indifferent to their own appearances as they age. And during this process, men shift their concerns to comfort and functions of the dentures. And women facing the physiological and psychological problems of menopause often present as exacting or hysterical patients who are very concerned with aesthetics. Coming to occupation, it helps in setting up a convenient appointment for the treatment procedure and in tooth selection and arrangement. So executives in high-stress jobs may exhibit bruxism. For professionals, appearance and retention may be more important than efficiency. For public speakers and singers, they may need greater attention to palatal shape and thickness and also perfect retention. Wind instrument players may require special positioning of anterior teeth, and the patients in high socioeconomic groups may be more demanding and critical, whereas those of low economic status may show disinterest and poor hygiene maintenance. Coming to location, some endemic disorders like fluorosis are confined to certain areas, and people from that locality may want characterization or pattern staining in their teeth for a natural appearance. Then coming to habits, past chewing, smoking and chronic alcoholism may modify the systemic status and concerns regarding hygiene, maintenance and wear of the denture. Pencil biting and nail biting, which may cause denture instability, and the parafunctional habits like crunching and bruxism may affect teeth selection and prognosis. So next one is the nutritional history. It is important to obtain a record of food intake of a patient over 3 to 5 days period. This helps in evaluating the nutritional status of the patient, and the ability of the oral tissues to withstand the stress of dentures is greater in a well-nourished patient. Dietary counseling is necessary in malnourished patients. So next one is the general health and dental history. A thorough and accurate medical history must be obtained during the diagnostic phase of complete denture therapy and must be updated as necessary. And the medical history provides important insights regarding the patient's dental prognosis. And the patients who exhibit good health generally are better prosthetic risk than those in poor health. Hence, the practitioner must be aware of local and systemic factors and must consider them during treatment planning. And the successful treatment requires an understanding of patient's general health, dental history, and thorough appreciation of the status of oral and perioral tissues, any existing prostheses, be they successful or unsatisfactory. Coming to health questionnaire, it's a convenient method of collecting basic information and personal data. It can be sent to the patient before the appointment or administered in the reception area if facilities permit its confidential completion. Dentists can then review and clarify the information as necessary in the private operatory as part of the clinical examination. Coming to medical history, no prosthodontic procedure should be commenced without evaluating the systemic status of the individual. It is very important to take the medical history of the patient before going to complete denture procedures. So first one is debilitating diseases. The most common one is diabetes mellitus. And these patients show excessive rate of wound resorption, hence frequent lining may be necessary. And the patients having high risk of opportunistic infections like candidiasis show delayed wound healing and also salivary flow impaired. And in tuberculosis patients, they are very contagious and necessary precautions are required. And in blood dyscrasia patients require specific precautions if pre-prosthetic surgery is contemplated. And the mucosa is also more sensitive to denture pressure. And these patients having debilitating diseases require specific instructions on denture or tissue care and also require special follow-up appointments to observe the response of soft tissues to the denture. Next one is the diseases of the joints. Rheumatoid arthritis and osteoarthritis are common diseases affecting the joints. If fingers are affected, then the patient will find it difficult to insert and clean the dentures. When the temporomandibular joint is affected, special impression trays are required due to poor mouth opening, and frequent occlusal correction may be necessary as jaw relations are difficult to record due to painful mandibular movements. In cardiovascular diseases, it is always advisable to consult the patient's cardiologist before commencing the treatment. And these patients will require shorter appointments. And in skin diseases like pemphigus, having oral manifestations which vary from ulcers to bullae, such painful conditions make the denture use impossible without medical treatment. Constant use of the prosthesis should be discouraged for these patients. And neurological disorders like Bell's palsy and Parkinson's disease will present problems related to denture retention, maxillomandibular records, and support for the musculature. And the patients need to be educated regarding these anticipated problems. So in oral malignancy patients, some complete denture patients require radiation therapy before prosthetic treatment. A waiting period should elapse between end of radiation therapy and beginning of the complete denture construction. Only the radiotherapist determines this waiting period, and the tissues having bronze color and loss of tonicity are not suitable for the denture support. Once the dentures are constructed, the tissues should be examined frequently for radionecrosis. In epileptic patients, they may aspirate or break the denture during the seizure. It will influence the selection of denture-based material and the teeth. Patient and close relatives may also need to be educated on quick removal of the dentures prior to or during seizures. And in climacteric conditions like menopause can cause glandular changes osteoporosis, and psychiatric changes in the patient. And these can influence treatment planning and the efficiency of the complete denture. And next one is medications. It can be an indication of a systemic problem, or dental treatment may be modified and influenced by the effect of the drug. So a common side effect of antihypertensives and antidepressants is the xerostomia or dry mouth, and this can decrease the denture retention and cause increased soreness. Diuretics cause changes in tissue fluids which affect retention and stability of the dentures. Psychotropic drugs can cause uncontrollable tongue or facial movements. Drugs can also act as synergist or antagonist to produce undesirable effects. Hence, the dentist must be aware of all the patient's medications. Coming to dental history, first one is chief complaint. It is recorded in patient's own words. It should be determined if the complaint is justified and realistic. It gives ideas about the patient's psychology. The next one is the patient's desires and expectations. It's important to find out what the patient expects from the treatment. The patient should be asked about his or her expectations. Unrealistic expectations will be detrimental to the success of the treatment, and the patient education regarding what is possible is very important in such cases. So past dental history. So the following information should be elicited. First one is the reason for tooth loss. If the periodontal disease was the reason, then more bone loss is anticipated, and it also helps in prognosis. Next one is the period and sequence of edentulousness. So longer the period, more will be the bone loss. By understanding the sequence, bone resorption pattern can be identified. And the previous dental and denture experience, the traumatic experiences will affect the attitude of the patient towards dental treatment. They will require more counseling and education. Patients' experience with previous dentures will give an insight into their attitude, desire, and expectations. So coming to the existing or current dentures, and the patient should be questioned about the length of the time he or she has worn the current dentures. Responses should be compared with clinical observations. The careful observation may provide valuable information about denture experience, denture care, dental knowledge, and parafunctional habits, etc. So coming to denture success, the patient should be asked about the aesthetics and function of existing maxillary and mandibular dentures. Responses may indicate the patient's ability to wear or adjust to complete dentures. Denture success for each arch should be rated favorable or unfavorable. Coming to pre-treatment records, it is very valuable information, and these records include information about previous denture, current denture, pre-extraction records, and diagnostic cast. Pre-extraction photographs, radiographs, cast, and facial measurements may prove helpful in denture therapy. These adjuncts may be used to recreate anterior aesthetics and facial support, as well as to aid in the evaluation of vertical dimension of occlusion. Here I am going to discuss clinical evaluation of completely dentulous patients. So the clinical evaluation includes extraoral and intraoral examination. In extraoral examination, it concerns principally with facial contours and symmetries, appearance of the teeth and their relationships with the lips in repose, palpation of the temporomandibular joints and of the submandibular and cervical lymph nodes, masticatory and facial muscles. So it includes facial examination, examination of muscle tone and development, lip examination, TMJ examination, and neuromuscular examination. Coming to facial examination, it includes evaluation of facial features, facial form, facial profile, and lower facial height. So facial features are length of the lips, lip fullness, lip support, philtrum, nasolabial fold, mentolabial sulcus, labial commissures and modulus. Then the vermilion border. The width of the vermilion border influences the degree of tooth display, and the size of the oral opening, it also influences the degree of tooth display and the texture of the skin. So in texture, rough or smooth and light color, rough texture skin will require the placement of rugged teeth, and the wrinkles on the cheeks show decrease in vertical dimension. Coming to the face form, Leon William has classified the facial form based on the approximate shape of the face as square, square tapering, tapering and ovoid. And the points on temporal, zygomatic, angle of the mandible are taken to form the lines on side of the face. And this helps in selecting the shape of artificial tooth for the patient. Coming to the facial profile, examination of the facial profile is very important because it determines the jaw relation and occlusion. Angle classified the facial profile as class 1 or normal or straight profile, class 2 retrognathic profile and class 3 prognathic profile. Forehead, base of the nose and chin points are considered for the classification. Coming to lower facial height. So determining the lower facial height is important to determine the vertical jaw relation. It is the picture showing restoring facial contours with dentures. In the first picture, it is without dentures. Here showing abnormal facial proportions. Here the bite collapse can occur when the teeth are lost, and an extreme situation occurs when all the teeth are lost. And the lower third of facial height is dramatically lost, causing the lips and cheeks to lose support and increase wrinkles. In the second picture, it is restoring with dentures. So here shows normal facial proportions, and the normal facial proportions are maintained when a person's teeth are replaced correctly. The lips and cheeks are properly supported, creating the optimal appearance. In this picture, it shows various lower facial height. So in the first picture, it is normal lower facial height. In second picture, it is decreased lower facial height. And in third picture, it is increased lower facial height. So if the face appears collapsed, it indicates the loss of vertical dimension, and decreased vertical dimension which produces the wrinkles around the mouth. And excessive VD will cause the facial tissues to appear stretched. Coming to muscle tone and development, the musculature surrounding the mouth plays an important part in the stability of the prosthesis. First and second picture shows the muscles of mastication, and third picture shows the muscles of facial expression. Muscles of mastication have been already discussed in my previous lectures. You can go through that. And here the muscles of facial expressions. So the facial muscles help in making the facial expressions. These are the various facial expressions. Coming to modulus. Modulus is contributed by following muscles. They are orbicularis oris, buccinator, levator angulae oris, depressor angulae oris, zygomaticus major, risorius, quadratus labii superioris and quadratus labii inferioris. And the meeting place where the 8 muscles meet, it's called modulus. And these muscles meet at the corner of the mouth. In Latin, modulus means hub of a wheel. It forms a distinct conical prominence at the corner of the mouth. If the thumb is placed inside the corner of the mouth and the finger outside the prominence, and then the lip and cheek are contracted, the modulus feels like a knot. The modulus becomes fixed every time the buccinator muscle contracts, which is a natural accompaniment of all chewing efforts. House classified muscle tone as class 1, class 2 and class 3. In class 1, the patient exhibits normal tone and placement of the muscles of mastication and facial expression. No degenerative changes are apparent. Class 1 is common in immediate denture patients because all other patients generally show degeneration. Class 2, the patient displays approximate normal function but slightly impaired muscle tone, and the maximum muscle function cannot be used following the loss of all natural teeth. And class 3, the patient exhibits greatly impaired muscle tone and function, and this is usually coupled with poor health, inefficient dentures, and loss of vertical dimension, wrinkles, decreased biting force, and drooping commissures. And muscle development, it's classified into class 1, 2, and 3. Class 1 is heavy, class 2 is medium, and class 3 is light. People with excessive muscle development have more biting force. So these are the extra-oral changes seen in elderly patients. They are facial profile convex, muscle tone is decreased, hollowing of cheek, increased nasolabial angle, drooping of corner of mouth, and depressed mentolabial sulcus. Coming to complexion, hair, eye and skin color provide useful guides in shade selection. Skin color also reveal underlying disease and pathology, and the patients with significant sun damage once referred to a dermatologist. Pale, anemic looking patients may have underlying systemic diseases and may require longer adjustment periods. And heavy wrinkles at the commissures and nasolabial fold usually suggest decreased vertical dimension of occlusion or poor support of facial musculature by the denture. Coming to the nasolabial angle, for a normal individual, it varies from 90 to 110 degrees, and which is decreased in an edentulous patient as the upper lip loses support from the maxillary incisors. So next one is examination of lip. It includes length, thickness, support, mobility and commissure. Coming to lip length. So the length of the lips is an important determinant in anterior teeth selection. Short lips will tend to reveal more of the tooth structure and also the denture base. And based on the length, lips are classified as long, normal or medium and short. So the upper lip length is measured from base of the nose to the inferior part of the upper lip, and the normal range in males it is 22 to 26 millimeter, and in females it is 20 to 22 millimeters. Here it is a device used to measure the length of the lip, and the device is papillometer. It comprises a vestibule shield, an incisive papillar rest and a vertical handle for measuring lip length. Next one is lip fullness. Apparent fullness of the lip is directly related to the support provided by the teeth and alveolar bone or denture base. And the lip fullness should not be confused with lip thickness, which involves the intrinsic structure of the lip. Coming to inadequate lip support. If the anterior maxillary denture teeth are set excessively palatally to reduce the overjet, can lead to a lack of lip support, producing vertical wrinkles in the face and results in the teeth appearing to be too short, a problem usually best corrected not by lowering the occlusal plane but by increasing lip support. Excessive lip support with the prominence of residual alveolar ridge or excessive thickness of labial flange can result in excessive lip support. Make the lip appear to be too full rather than displaced. Also can make the lip appear thick or short. An obliterated, philtrum or mentolabial fold suggest excessive support. Next one is correction of lip support. Problem with lip fullness is in the patient's reaction to changes. If the existing dentures have the teeth set too far palatally, the patient may feel that new and corrected tooth arrangement makes the lip too full. Extra time will be needed at the trying of the wax dentures to ensure that the patient is comfortable with the agreed design. Coming to thin and thick lips. So lip thickness is also very important. And the patients with thin lips present special problems. Any slight change in the labiolingual tooth position makes an evident change in the lip contour. It's critical that when overlapping of the teeth may distort the surface of the lip, both the arch form and the individual tooth positions can have effect on lip contour. Thick lips give the dentist a little more opportunity for variations in the arch form and individual tooth arrangement before the changes are obvious in the lip contour. So coming to lip mobility, based on mobility, lips are classified as normal or class 1, reduced mobility or class 2 and paralyzed or class 3. Coming to commissures, the lips are examined for fissures, cracks or ulcers at the corners of the mouth. If present, these indicate vitamin B deficiency, candidiasis or prolonged overclosure of mouth due to decreased VD. In this picture shows angular cheilitis due to decreased vertical dimension. Coming to TMJ and masticatory muscle examination. TMJ and associated muscles should be examined for pain by palpation or mandibular movement. Range of opening, deviation, clicking and crepitus should be noted. It must be decided if complete denture construction will solve some of the problems associated with TMJ and explained to the patient. Severe pain in the TMJ indicates increased or decreased vertical dimension. And the TMJ movements can be classified as class 1 coordinated, class 2 jerky and class 3 restricted. Coming to neuromuscular evaluation, the patient is to be observed from the time when he or she enters the clinic. The patient's gait, coordination of movements, ease with which he moves and his steadiness are important points to be considered. Speech and coordination are two entities evaluated in the neuromuscular evaluation. Coming to speech, should have a basic knowledge of speech, particularly its articulatory component. Articulation is the modification of speech sounds by structures of throat, mouth and nose. Fortunately, the neuromuscular activity that produces speech can adapt to or accommodate a certain amount of structural change. Relationship of the positions of the teeth, lips and tongue in the articulation of speech are very important. Assessment should be made during the diagnosis appointment to identify existing problems and determine the potential for improvement. Coming to coordination, patients with good neuromuscular coordination can be expected to learn to manipulate dentures relatively quickly and likewise adapt readily to the new dentures. Patients with poor coordination or a neurologic deficit may never adapt to a denture completely. Neuromuscular coordination can be classified into class 1 excellent, class 2 fair and class 3 poor. In this lecture, I would like to include intraoral examination in detail. In intraoral examination, first and foremost, we have to examine if there is any teeth present. If any teeth exist, then we are planning for the various treatment options like immediate denture, over denture or single complete denture. Coming to mucosa, there are various types of mucosa like lining mucosa, specialized mucosa, and masticatory mucosa. And the mucosa of cheeks, lips, floor of the mouth, residual ridge, hard palate, and soft palate is evaluated for the color, thickness, and the condition. Color of the mucosa. Redness is a sign of inflammation which could be due to ill-fitting dentures, infections, smoking, and systemic diseases such as diabetes. It's important to eliminate the cause and allow the tissues to return to normal before impression making. And white patches and brown or blue pigmented spots should be noted. If the cause is uncertain, a biopsy is indicated. Thickness of the mucosa. The quality of the mucoperiosteum may vary in different parts of the arch. And the variations in thickness of mucosa makes it very difficult to equalize the pressure under the denture and to avoid soreness. House classified thickness of mucosa as class 1, class 2 and class 3. In class 1, normal uniform density of mucosal tissue approximately 1 mm thick. Investing membrane is firm but not tense and forms the ideal cushion for the basal seat of the denture. In class 2 mucosa, it can be of two types. Soft tissues have a thin investing membrane and are highly susceptible to irritation under pressure. And soft tissues have mucous membranes that are twice the normal thickness. And in class 3, soft tissues have excessively thick investing membranes filled with redundant tissue. Condition of the mucosa. House classified the condition of mucosa as class 1, which is healthy, class 2 it's irritated, and class 3 is pathological. Next one is residual alveolar ridge. We will discuss this topic under the following headings: arch size, arch form, ridge relationship, ridge forms, ridge contour, and ridge relation. Under ridge relation, inter-ridge distance, ridge parallelism, and positional relation will be discussed. Coming to arch size. It is classified into class 1, 2 and 3. Class 1, it is large and it is best for retention and stability. So greater the arch size, the larger is the contact and support, and hence the greater is the retention. In class 2, it is medium, good retention and stability, but it is not ideal. And class 3, it is small, difficult to achieve good retention and stability. So amount of basal seat availability, which is determined by the size of the arch. And more stability and retention is offered when the arch size is increased. Arch form, it is class 1, class 2 and class 3. Class 1 is square. It is the best form to prevent rotational movement. Class 2 is tapered. It offers resistance to movement but to a lesser degree. And class 3 is ovoid. They influences support and tooth selection. If opposing arches do not have the same form, the difficulty in tooth arrangement can be anticipated. Next one is ridge relationship. According to angle, it is classified into class 1, class 2 and class 3. Class 1 is normal. Here the anterior segment of mandibular ridge directly below or slightly posterior to the maxillary anterior ridge. In this picture, it's clearly shown that the anterior segment of the mandibular ridge, which directly below or slightly posterior to the maxillary anterior ridge. And in class 2, it is retrognathic. In this picture, here the anterior segment of the mandibular ridge retruded beyond the normal position. And in class 3, it is prognathic. Here the anterior segment of mandibular ridge protruded beyond the normal position. Coming to ridge forms, in maxilla, class 1 is square, class 2 is tapering, class 3 is flat. And in mandible, class 1 is inverted U-shaped or tall to medium with broad crest. Class 2 is inverted U-shaped, short with flat crest, and class 3 is unfavorable. That is tall thin inverted V, short thin inverted V, inverted W and undercut. So the maxillary ridge and vault form should be classified as class 1, it is square to gently rounded. It is most favorable. Height resists lateral displacement. Parallelism of its sides maintains the seal to resist vertical displacement. Class 2 is tapering or V-shaped. Here V-shaped vault is there. Resists lateral displacement and vertical displacement breaks the seal. And class 3 is flat. Here it's a flat vault and resists vertical displacement and little resistance to lateral displacement. Coming to the mandibular ridge form. So first one is inverted U-shaped, parallel walls from medium to tall with broad crest. Inverted U-shaped, short with flat crest is the class 2. And class 3 is unfavorable, that is inverted W, short inverted V, tall thin inverted V and undercut. So next, coming to ridge contour. Ridges can be classified based on their contour as high ridge with flat crest and parallel sides. It is the most ideal form. Then flat ridge and knife-edged ridge. So the Atwood has classified the residual ridges as orders 1 to 6. It influences support and stability of the dentures. And the classification is order 1, it is pre-extraction. Order 2, it's post-extraction. Order 3, high well-rounded. Order 4, knife edge. Order 5, low well-rounded. And order 6 is depressed. Ridge relation. Under ridge relation, inter-ridge distance, parallelism and positional relation. Coming to the inter-ridge distance, class 1 is ideal inter-arch space to accommodate the artificial teeth. Class 2 is excessive inter-arch space and class 3 is insufficient inter-arch space. So excessive inter-arch space will be due to excessive residual ridge resorption and these patients will have decreased retention and stability of the dentures. And in class 3, that is insufficient inter-arch space, it will make teeth arrangement a difficulty. However, stability of the denture is increased in these patients due to decrease in leverage forces acting on the denture. So, increased inter-arch space which cause increased leverage forces. So, there is decreased retention and stability of their dentures. So, coming to the ridge parallelism, this affects denture stability as non-parallel ridges will cause movement of the bases when teeth occlude due to unfavorable direction of the forces. And it is classified as parallel and non-parallel. Class 1, the both ridges are parallel to the occlusal plane. Class 2, this mandibular ridge is divergent from occlusal plane anteriorly. And class 3, maxillary ridge is divergent from occlusal plane anteriorly or both ridges are divergent anteriorly. Next one is positional relation. This affects tooth arrangement and denture stability. As maxilla resorbs, the crust appears to move upwards and inwards. As mandible resorbs, the crust appears to move downwards, forwards and laterally. So this is the positional bridge relation, class 1, class 2 and class 3. Coming to hard palate, it is classified into U-shaped, which provides good retention and stability, V-shaped, which provides least retention, and flat, it provides poor retention and stability. Soft palate, U-shaped, it is ideal for both retention and stability. V-shaped, retention is less as the peripheral seal is easily broken, and flat, reduced resistance to lateral and rotatory forces. Based on the degree of flexure that the soft palate makes with the hard palate and the width of the palatal seal area, the soft palate configurations can be classified into class 1, class 2 and class 3. So while examining soft palates, it is important to observe the relationship of soft palate to the hard palate. And the relationship between the soft palate and the hard palate is called palatal throat form. And on this basis, soft palates can be classified as class 1 soft palate, class 2 soft palate and class 3 soft palate. In class 1, it is almost horizontal with little movement making angle of less than 10 degree with hard palate. It is the most favorable and it allows best tissue coverage, that is more than 5 mm, and development of a wide posterior palatal seal. In class 2, soft palate makes a 45-degree angle to the hard palate, and class 3, here it makes a 70-degree angle with the hard palate. It is least favorable and it allows least tissue coverage, less than 3 mm. Palatal throat form. The House classified palatal throat forms into class 1, class 2 and class 3. Class 1 palatal throat form, it is large and normal in form and it is relatively with an immovable band of tissue which is 5 to 12 mm distal to a line drawn across the distal edge of tuberosities. So it is a large and normal in form, and here immovable band of tissue 5 to 12 mm distal to a line drawn across the distal edge of tuberosities. Class 2, it is medium sized and normal in form. Here resilient band of tissues 3 to 5 mm distal to a line drawn across the distal edge of tuberosities. And class 3, it usually accompanies a small maxilla. The curtain of soft tissue turns down abruptly 3 to 5 mm anterior to a line drawn across the palate at the distal edge of tuberosities. And class 3 soft palate is commonly associated with V-shaped palatal vault, and class 1 or class 2 associated with flat palatal vault. Coming to palatal sensitivity, it's evaluated by running a mouth mirror over the soft palate. Gagging is the normal defense mechanism to prevent foreign objects from entering the trachea. It is classified into class 1 normal, class 2 subnormal or hyposensitive, and class 3 is hypersensitive or supernormal. So, exaggerated gag reflex can compromise prosthodontic procedures like impression making, and the causes are systemic, psychological, physiologic and iatrogenic, and the management of such patients may be clinical, psychological or pharmacological. So the gagging can be controlled by careful handling of impression procedure, constant reassurance, and diverting the patient attention from the procedure. Lateral throat form. It is the distance between the floor of the mouth and the middle of retromolar pad when the patient protrudes the tongue 1/4 inch beyond the edge of lower lip. So Neal classified the lateral throat form according to the extent of anterior movement of retromalahyoid curtain as tongue extended anteriorly. And it is classified into class 1 deep, class 2 it's moderate, that is any position in between 1 and 3, and class 3 is shallow. These are the classification of lateral throat form according to Neal. And here it is a customized instrument which is used to measure the depth of lateral throat form. Coming to border attachments, this is the height of attachment and this is the ridge crest. If away from the ridge, then good border seal can be achieved. So the border attachments can be classified into class 1, class 2 and class 3. Class 1, the attachments are placed away from the crest of the ridge and they are high in maxilla and low in mandible with relation to ridge crest, and there is at least 0.5 inches distance between the attachment and the crest of the ridge. Class 2, distance between the crest of the ridge and the attachment is around 0.25 to 0.5 inches, and in class 3, the distance between the crest of the ridge and the attachment is less than 0.25 inches. Frenal attachment, according to House, it is classified into class 1, class 2 and class 3. In class 1, high in the maxilla or low in the mandible with respect to crest of the ridge. Class 2, it's medium, and class 3, frenal encroach on the crest of the ridge and may interfere with the denture seal. And the surgical correction may be required. All the lingual tissues of the mandible are classified as muscle attachments. So saliva. Quality and quantity of saliva are crucial factors in a patient's ability to tolerate dentures. Both the flow rate and viscosity are important to denture success. Normal resting salivary flow is about 1 ml per minute, and a flow of medium viscosity at this rate lubricates the mucosa and assists retention of complete dentures. Major salivary glands orifices should be examined to ensure that they are open. The amount and consistency of saliva affects denture retention and construction, and the amount of saliva can be classified as class 1 normal, class 2 excessive and class 3 xerostomia. So if there is a dry saliva, then the retention can be compromised and the potential for soreness. If there is excessive saliva, then it complicates the denture's reconstruction, especially in impression making. In quality, thin or watery type and thick droppy type. In thick droppy saliva, the denture wearing is more difficult. Okay, to check the consistency of saliva, we can use string test. Let's move on to the tongue. Tongue should be examined for its size and position. Tongue movement, muscular coordination and position control the dentures during speech, mastication and deglutition. Coming to the size of the tongue. Size can be classified into normal, enlarged and small. The presence of a large tongue which decreases the stability of the denture and it compromises the impression making, and the tongue biting is most common after the insertion of the dentures, and the small tongue does not provide adequate lingual peripheral seal. According to House, the tongue can be classified into class 1, class 2 and class 3. In class 1, normal in size, development and function, sufficient teeth are present to maintain this normal form and function. In class 2, the teeth have been absent long enough to permit a change in form and function of the tongue. And class 3, it is excessively large tongue. All teeth have been absent for an extended period of time, allowing for abnormal development of the size of the tongue. Insufficient denture can sometimes lead to development of class 3 tongue. Next, going to position of the tongue. The position of the tongue greatly affects the ability of a patient to successfully wear complete denture. According to Dr. C. Wright, he classified the tongue position into 3, that is class 1, class 2 and class 3. In class 1, the tongue lies on the floor of the mouth with the tip forwards and slightly below the incisal edges of the mandibular anterior teeth. That is class 1. Class 2, the tongue is flattened and also broadened, but the tip is in normal position. And class 3 is the tongue is retracted and depressed into the floor of the mouth with the tip curled upwards, downwards or assimilated into the body of the tongue. Class 1 position is ideal because in such a case the floor of the mouth is at an adequate height, hence the lingual flange of the denture contacts it and maintains the peripheral seal of the denture. But in both class 2 and class 3 cases, the floor of the mouth is too low. Hence, the dentist tends to overextend the denture flange. This will lead to loss of retention instead of obtaining peripheral seal because the denture flange impinges on the tissue and gets displaced during the activation of the floor of the mouth. In the first picture, for long-term edentulous patients, the intrinsic muscles of the tongue which may spread to fill in the extra available space. And this may cause various management and adaptation problems both during the fabrication as well as the patient's subsequent adaptation to the space restriction imposed by the presence of new prostheses. In the second picture, it shows a firm, broad and well-developed ridge accompanied by a favorable tongue size and position suggests a good prognosis. Coming to torus palatinus, it is found at the midline of a hard palate. Small ones can be accommodated by relief of denture base. Surgical excision if fills palate to occlusal level or extends beyond the vibrating line, and treatment deferred for 2 to 6 months. Mandibular tori, it is found commonly in lingual premolar region and it is difficult to provide relief without breaking border seal of the denture. Surgical removal is necessary for successful denture construction. Certain ridge defects like exostosis, which may pose a problem while fabricating a complete denture, and the redundant tissue that is common to find a flabby tissue covering the crest of the residual ridges, and these movable tissues tend to cause movement of the denture when forces are applied, and this leads to loss of retention. So there are various modified impression procedures for the flabby tissue. Next one is enlarged tuberosity. It may also associated with Kelly syndrome, wherein the anterior part of the maxillary complete denture rotates into an upward position while the posterior tuberosity part appears to grow downwards. This morphological predicament is usually associated with an untreated Kennedy class 1 type of mandibular dentition, and associated enlarged tuberosity may need to be surgically reduced to accommodate the replacement mandibular posterior dentition. Next is Epulis fissuratum. It may be due to various overextended flanges in the dentures. This is the papillary hyperplasia. Here it occurs on the anterior region of the palate in long-term denture varus, and often the tissue is inflamed and it is referred to as inflammatory papillary hyperplasia, and it is more prone to infection, frequently with Candida albicans, although the infection must be treated before new dentures are made. Recurrence is likely unless the hyperplastic tissue is removed. Coming to infection, various oral fungal infections are common in edentulous patients, particularly in maxillary denture related stomatitis, and concomitant inflammation of the corners of the mouth, that is angular cheilitis, should raise suspicions of Candida albicans infection. Then what are the investigations to be taken by the completely edentulous patient? Radiographic examination. So, panoramic radiograph, lateral cephalometry, and intraoral radiography. Any pathologies or any ridge resorption can be found out using the panoramic radiograph, and the ridge relation and facial profile can be assessed using lateral cephalometry, and to validate any suspicious areas specifically, then we can use intraoral radiography. So the radiographic images are necessary to ensure that abnormalities and pathosis are identified and if needed addressed before complete denture management is undertaken. So the interpretation of OPG, it can be used for any defects in structure or reactive new bone formation, then bone expansion, then any unerupted teeth or retained roots, then foreign bodies or radiolucencies and radiopasties, or maxillary sinus checked for inflammation, cyst, polyps and tumors. In the first picture, this OPG shows it identifies the superficial position of the mental foramina, while in A it shows the favorable ridge morphology and tooth roots in posterior maxillary regions, and the compromised ridge morphology is quite clear in picture B, together with superficially located mental foramina. Both the two-dimensional quantity of bone support, size and location of the maxillary sinus and the presence of an alloplastic only graft in the mandible are clearly shown in picture C. This is a typical example of the sort of scout view for selecting implant host sites before more sophisticated imaging is undertaken. So the ridge resorption can be classified into class 1, class 2 and class 3. Class 1, it is mild resorption, loss of 1/3 of original height. Class 2, moderate, loss of 1/3 to 2/3, and class 3, it is severe, loss of 2/3 or more. Coming to photographic images, so the pre-extraction photographs can be useful for determining the teeth selection and arrangement. Then diagnostic and study cast, it provides accurate information on tooth size and the arrangement, and assist in making decisions on pre-prosthetic surgery. And also the undercuts can be observed directly or determined precisely with the aid of a dental survey. So the completely edentulous patient, according to ACP 1999, it is classified into class 1, class 2, class 3 and class 4. Class 1 is ideal or minimally compromised. Class 2 is moderately compromised. Class 3 is substantially compromised. And class 4 is severely compromised. And the benefits of the system is better patient care, improved professional communication, better screening tool to assist dental school admission clinics, standardized criteria for outcomes assessment. So the diagnostic criteria include bone height, mandibular, then maxillary residual ridge morphology, mandibular muscle attachments, and maxilla-mandibular relationship. Here is a table showing diagnostic criteria in detail and the classification of completely edentulous patients according to ACP-99. So in class 1, it's ideally or minimally compromised. Bone height, it is type 1, 21 mm or greater. Its morphology is type A. Muscle attachment is type A or B. Maxilla-mandibular relationship is class 1. In class 2, moderately compromised. Mandibular bone height is type 2, that is 16 to 21 mm. Its morphology is type B. Muscle attachment is type A or B. Maxilla-mandibular relationship is class 1. Then class 3, it is substantially compromised. Bone height is type 3, that is 11 to 15 mm. Its morphology is type C. Muscle attachment is type C. And the maxilla-mandibular relationship is class 2 or 3. And class 4, severely compromised. Bone height is type 4, that is 10 mm or less. Its morphology is type D. Muscle attachment is type D. And the maxilla-mandibular relationship is class 2 or 3. So coming to the development of a treatment plan, after all the intraoral and general physical and dental conditions have been recorded and radiographs, cast and other visualites are in hand, they can be interpreted and the treatment plan can be developed. And the details of the specific observations determine the details of the treatment required. A primer on treatment options. They are adjunctive care and prosthodontic care. What is adjunctive care? Adjuvant therapy, it's also called adjunct therapy or adjunctive therapy or care, is a therapy that is given in addition to the primary or main or initial therapy to maximize its effectiveness. So it includes elimination of infection, elimination of pathosis, surgical improvement of denture support and space, tissue conditioning and nutritional counseling. And prosthodontic care is that it's for a patient destined to become edentulous and also for an edentulous patient. So for a patient destined to become edentulous, it is removable partial dentures, that is conventional, interim or hybrid complete denture or removable partial denture, and transitional. Complete denture, that is immediate or conventional, definitive or interim, tooth, implant or soft tissue supported. And for an edentulous patient, complete dentures, that is soft tissue supported, implant retained dentures, implant supported dentures, in implant supported, fixed and removable. Various clinical conditions that suggest the need for teeth extractions. Advanced periodontal disease with severe bone loss around the teeth, severely broken down crowns with subgingival residual tooth tissue that cannot be adequately restored, fractured roots, periapical or periodontal abscesses that cannot be successfully treated. Then coming to the treatment plan decisions. There are tissue conditioning or finger massage, that is type of treatment material and its frequency. Then pre-prosthetic surgery, that is procedures proposed and staging. Then the impression procedures, primary, final and the material used. And the jaw relation and articulator, that is spaceboard transfer, articulator and its control settings. Then tooth selection, that is shape, mold, material and number. And then denture based material. Why treatment plan? It addresses the patient's needs. It lists specific treatment, specifies logical sequence. It enables dentists to estimate the operating time, laboratory time, calendar time and fees, and thus enables patient to various informed consent, that is treatment, time and fees. And by estimating the operating time, laboratory time, calendar time and fees, dentist delivers the patient specific delivered care. And thus patient receives delivered care through the informed consent. And next one is financial implications. Must consider the financial implications of any selected treatment plan. Optimal treatment plan is useless if the patient cannot afford it. Prioritize the need for different treatments based on the significance of identified problems. Treatment plan should balance the patient's needs and ability to pay. So coming to the summary for the treatment plan. It requires a broad knowledge of treatment possibilities and detailed knowledge of patient needs determined by a careful diagnosis. Treatment beyond the competency of the treatment planner should be referred to more experienced. The treatment planning must have a parallel process of developing a prognosis. Thus, the treatment planning can be summarized as the process of matching possible treatment options with patient's needs and systematically arranging the treatment in order of priority, but in keeping with a logical or technically necessary sequence. So that's all about the diagnosis and treatment planning in completely edentulous patients. And here is a model of case sheet for completely edentulous patients. It including the patient data like name, age, OP number, race, then address, phone number, okay, then chief complaint, history of present illness, then the systemic status, any systemic disorders, then the patient's personal history, that is diet, habits, then the dental history, then any previous dentures are there, then earlier denture experience, pre-extraction records, mental attitude. Then next one is the extraoral examination. In that, facial form, that is outline form, profile, then muscle tone, then lips, under lips length, thickness, support, mobility and commissures should be noted. Then the complexion should be noted. Then the temporomandibular joint, tenderness, mouth opening, deviation, clicking. Then the neuromuscular evaluation, speech and coordination should be evaluated. Then coming to the intraoral examination, arch form, Edwards classification of residual ridge forms, then the interarch space, ridge parallelism, ridge relationship, lateral throat form, then soft palate, then coming to mucosa, healthy, inflamed or pathologic, then mucosal or frenal attachment, then the saliva, that is quality and quantity, then tongue, that is size and position, or any other relevant details should be noted. Then the examination of all denture, then various investigations like radiographs, OPG, lateral cephalogram or any other. Then finally concluded with the diagnosis, that is class 1 ideally or minimally compromised, class 2 moderately compromised, class 3 substantially compromised and class 4 severely compromised. Then at last the treatment plan, that is tissue conditioning, pre-prosthetic surgery, impression procedure, jaw relation and articulator, then tooth selection, wax trying, denture insertion, post-insertion follow-up, then finally prognosis. Okay. That's all about the diagnosis and treatment planning in completely edentulous patients. Thanks for watching. Stay home, stay safe.